Florida legislators recently passed legislation to prevent advanced practice nurses in Florida with doctorates from using the honorific doctor. The state House and Senate bills, which were ultimately vetoed, propose that nurses with doctorates who introduce themselves to patients as Dr. Smith, nurse practitioner, could face disciplinary action.
We believe that these legislators and physicians need a little history lesson and a bit of a reality check. Referring to only physicians as doctors when other clinicians hold doctorates sends a divisive and hierarchical message that erodes interdisciplinary respect and collaboration. It also enables power dynamics contrary to modern healthcare's push to dismantle paternalism.
That was Stephanie W. Edmonds, who is Principal Research Nurse Scientist at Abbott Northwestern Hospital, and Ginny Ryan, a professor of obstetrics and gynecology and the Division Chief of Reproductive Endocrinology and Infertility at the University of Washington School of Medicine. They were reading from their recent First Opinion essay on why patients shouldn't call their healthcare provider doctor, even if they're an MD. I'll bring you our conversation about honorifics, the different kinds of doctors, and patient care after a quick break.
I'm Jesse McQuarters, branded content editor for STAT. Recognizing the breadth and diversity of America's 53 million family caregivers, how can we better know and see these important unsung heroes? Lisa Wilson, head of Caregiver Advancement Strategy and Experience at United Healthcare, offers insights.
Family caregivers are a cornerstone of our health system, but it can be challenging to support them in the moments that matter. United Healthcare is breaking down the barriers to identifying and engaging caregivers. For example, we're making it easy for caregivers to establish necessary HIPAA permissions and encouraging self-identification. The more we know about this population, the more we see them, especially early on in their caregiving journey, the better support we can provide.
For more information, visit uhc.com/caregiving.
Welcome to the First Opinion podcast. I'm Tori Bosch, editor of First Opinion. First Opinion is STAT's platform for interesting, illuminating, and provocative articles about the life sciences writ large, written by biotech insiders, healthcare workers, researchers, and others. Stephanie and Ginny, welcome.
Thank you for having me, Tori.
Thanks, Tori. It's a pleasure.
Now, you are both doctors in different senses of the term. So what are your educational backgrounds?
I have a Ph.D. in nursing. So I first got my bachelor's degree in nursing. Then I eventually got my master's degree in public health. And then finally, in about 2017, got my Ph.D. in nursing.
And I, pretty traditional path towards an MD, bachelor's degree, and then directly into an 4-year MD. I eventually got my master's in bioethics afterwards when I was practicing medicine.
And I should also note that you had a third co-author on your essay, Alden Bush. And what's Alden's background?
Alden is a psychiatric nurse practitioner, and he has a DNP, or a doctorate of nursing practice.
So you're 3 doctors, but you're arguing that the term doctor isn't something that should be used with patients. So tell me a little bit about that.
Having this kind of structure of using honorifics. So honorifics, just to be clear, are things like Mr., Mrs., Ms., doctor, captain, that kind of thing. And so using those honorifics is a sign of respect. But we should also be respecting our patients the same way that they should be respecting us. And so if we're not going to use honorifics with our patients, we probably shouldn't expect the same.
I mean, Stephanie brought this to my attention, this sort of these events that are happening out there just at a time when, in healthcare, I'm seeing a lot of sort of grappling with, racism for sure, and a lot of trauma that women are bringing into, I'm a women's healthcare provider. And we're as we all should be in the country, dealing again with a lot of, structural racism, especially in our department. We're dealing with that a lot right now as well. And then I'm a delegate to the American Medical Association. And so I see when we were just there for the annual meeting in June, this kind of, how is the AMA kind of trying to tackle scope of practice issues? So it's really fascinating to me, even to be at those AMA conferences. I'm used to being at very multidisciplinary conferences where it's sort of focused on a healthcare area like women's health or reproductive medicine and that sort of thing. It's very multidisciplinary. It's, from social workers and nursing and, just across the gamut, focused on a particular disease process or healthcare, right? And then this was very much like, we are MDs. And it was very disconcerting to me, quite honestly. And I was sort of like, wow, I didn't realize that everybody was so concerned about the scope of practice issue. And so when Stephanie brought this to my attention, I thought this is a really great opportunity to kind of just to tackle this, the three of us, to think about it from our different perspectives and to kind of try to get to the meat of the issue.
And so as you're sort of gesturing toward there are really two things going on in the essay that you wrote that tap into kind of bigger questions happening within medicine right now. So there's this scope of practice idea, Ginny, that you alluded to, which is, as I understand it, trying to decide who in medicine handles what. And my understanding is that a lot of MDs are concerned that people with doctorates who are not MDs may be practicing beyond their education or training. And then we have this other phenomenon of trying to kind of become more patient-centric and trying to make medicine less scary, perhaps, to the patient and empower the patient. And those two ideas collided spectacularly in your essay, and there is a great deal of response to it. Can you talk a little bit about the responses that you've seen to the essay?
Yeah, I think we've had really positive and some, a little bit more negative comments. I'll speak first to the negatives because I like to end on a positive. But really, I think there's this, kind of movement that Ginny alluded to, that some physicians in particular are concerned about scope creep is what it's called. So maybe nurse practitioners, they're physicians feeling like nurse practitioners in particular are not trained, educated enough to do some of the things that physicians traditionally do, diagnose, treat. And so there's actually like a Reddit of noctor, like kind of making fun of people who are not doctors. And so obviously that group has been a little vocal about, kind of accusing the nurses as the authors of being jealous of not being physicians or, just kind of, it's kind of just this rhetoric of less than, that I see a lot. And, and there's some discussion too about how, patient confusion. So we bring that up in the article, but people still are concerned that patients would be confused if they weren't sure who their doctor was, or their physician. And then we've also had really positive, I've had people reach out to me who are not physicians. I had pharmacists, dentists, and even a physical therapist reach out and said that they really appreciated the article. And I know Ginny, I'll let Ginny talk about her dean.
Yeah. So I'm not as active on social media for my own mental health as Stephanie is and as many people are, but I have sent it around. But in fact, this dean reached out to me unsolicited. She sent me a message saying, I saw this come out. I just read this and I was really impressed. And she has a child who has a doctorate degree, not in medicine. And she was very appreciative of it. And I have a great deal of respect for her. So that made my day. And I think that was great to hear from a physician in leadership. And I sent it around to my chair as well. And she also was very supportive. We had just had a 2-hour faculty breakfast meeting where we were really trying to grapple with a new cultural commitment for our department. And so I said, this is really timely. You know, what do you think about this in us moving forward with concrete steps to kind of deal with, making this new cultural commitment? And she was very open to that conversation too. And just of note, our faculty, what I like about our faculty as one of a number of things is that we have nurse practitioners, nurse midwives on our faculty, which is great, which is not something that I've seen in a lot of different schools of medicine in departments. So it was really reassuring. I think that we're trying to take some good steps in medicine to grapple with some of these things. And I think they're all interconnected. I like the word that you used, Tori, collision of these things. I think it's a great time to have the conversation.
Yeah, and I want to talk a little bit more about, the sort of concern that some MDs have about this, about not using the honorific doctor, but also about scope creep. Ginny, I think one thing I often hear is that doctors say, I went through 4 years of medical school and however many years of residency, and, I have earned the doctor in a way that perhaps others haven't. And what is your response to that?
Yeah, I think it's tricky because I think as a woman in medicine, I think it takes a long time for you to have sort of earned any respect, unfortunately, right? And so you keep hearing for so many years in your training, that you can't be the doctor, you're a woman, or you're too young, or you're too pretty, or some ridiculousness, right? And so I think to finally kind of get to the point where you have that degree, and then that and then you ensure that, people will use that term so that they really appreciate, like, look, I have this training, I'm in the right position here to be helping you out, and so it is a tricky thing to then say to everybody, no, let's stop using that, that we don't need to use that. So, you shouldn't have to have that honorific to have that respect, but that is the tricky thing. And so I think about it, and I think about how I would actually put this into practice in my practice. And, because we also have this issue of, we'll have a male and female physician, and they'll refer to the male as doctor, but not to the female. And so it's like, we fought so hard to be just like, you have to, just like them, I have that same training. And so to pull back from that is very tricky. And yet at the same time, it's an awkward position to be in. I work with 2 other faculty in our division who are, one's a nurse midwife and one's a nurse practitioner. And they're fabulous. And they make, they know, as we all should, what our limits are and what we can, provide care in. And it seems ridiculous to me to be on a meeting and they're referred to by their first name and I'm referred to as doctor. And I almost get to the point of saying, okay, nurse practitioner, whatever, if you're going to call me doctor, whatever, it just seems really ridiculous. So we're in this kind of awkward situation. And I think, but there's so many things to kind of break down in this, but the scope of practice does come across in these AMA meetings as just like this paternalistic, you hear it from the older physicians and they're just like, just trying to protect the, just like, no, you can't do this. We've earned this. And it just smacks of, I don't even know what, but it's not, it doesn't reflect well in our profession, I guess I would say. Like, let's be open to this conversation and all of the layers of it.
Now, how do you both introduce yourselves to patients these days?
Yeah, this is Ginny. I'll say I'm Ginny Ryan. I'm one of the physicians in our practice. I think ever refer to myself as Dr. Ryan, interestingly, I guess, when I think about it. But yeah, that's how I introduce myself.
Yeah, and just due to the nature of my job, I don't necessarily communicate a lot anymore one-on-one with patients. But if I do, or when I did, it would kind of more describe my role. So because my role is so kind of unique. So, but I always say I'm Stephanie, I'm a nurse, or I'm a nurse researcher, because a lot of times people don't know what a nurse scientist means, but they do understand research. But yeah, just really clarifying my role, but definitely on a first name basis.
Do either of you ever encounter patients who are genuinely confused about whose role is what?
I think that happens all the time, even when we make an effort to, it says it on our name tags. We make sure we're wearing our name tags and we introduce ourselves with, I think that, it happens all the time. You'll talk to patients in the next visit and they'll say, nurse so-and-so, and that person was a medical assistant, or they'll say, Dr. So-and-so, and it was a sonographer, which is, I think usually I'll just clarify that just so that it's more about communication. They're not going to get the same answers from different people on our team, right? So I try to clarify that. But I think, it happens all the time. We used to, at my former practice, at a new patient visit, we had a piece of paper and it had all sort of the roles listed, and we would put people's names down, because I think, and it's true, as just interacting myself as a patient in the medical system, it's so many people that you meet, right? And you just, who is who, and who do I refer to, and who is sort of, who's the person I can send these questions to, and how do I communicate? So I think it's all about that in my mind. But yeah, it happens all the time for sure.
Yeah, especially since often, patients are in a kind of confusing situation when they're especially if they're in a situation in which they're seeing multiple providers in one visit, something's going on. And so remembering exactly whose role is what is maybe not top of mind at that moment.
Absolutely.
No, I mean, we all talk about how we struggle remembering people's names just as humans. And so to remember their names plus what they do in probably a pretty anxiety-producing situation, I think there's always going to be some confusion and need to do role clarification. That really doesn't have anything to do with calling somebody their first name or doctor.
Are there any moments when the sort of traditional hierarchy of titles within healthcare is still important? Like, are you more concerned about who's in charge, or ever? I mean, when people have criticisms about who gets to use the honorific doctor, like, is there something to that at all, just in terms of when the hierarchy might be useful?
So just a doctorate in general signifies I have kind of the highest level of education that a person can achieve. And so I'm an expert in X. And so that's sometimes where I think using that honorific doctor just to kind of signify that you have that expertise is really useful. But I will say too, like particularly like a Ph.D. like I have, you are an expert in this very tiny little thing. And so yes, like you should talk to those experts if you need to consult with somebody on that very specific thing. But overall, that I don't think it matters too much.
Yeah, that's an interesting question. I mean, I think about ultimately, even if you're sharing decision-making, both either with your patient or with a team tackling a certain problem in your system, it's important to kind of identify where the buck stops, I suppose, right? But that doesn't always end up meaning the person with the doctorate. I think about the IT things we struggle with, and and we'll have some physicians on this big group meeting, and we're like, don't ask us what we should do in this IT issue, right? So I think it's always important to clarify your role in a given situation and the limits of your expertise. But yes, I mean, as far as leadership goes, sometimes that means you're the leader or one of the leaders in an arena, but sometimes it does not. So.
And I want to talk a little bit about this legislation that we saw happen in Florida that you mentioned at the beginning of the episode. Now, as you said, Governor Ron DeSantis ended up vetoing it. But, it still seems sort of wild to me that they were legislating who gets to use the term doctor in the first place. So Can you tell me a little bit about what happened there? I mean, is this something you're seeing in other states as well?
Yeah, and I'm not very sure about which other states have this legislation. I'm pretty sure that California might, because now there's some lawsuits related to nurse practitioners who have been fined or kind of slapped on the wrist for referring to themselves as Dr. so-and-so nurse practitioner. And so I think some of those nurse practitioners are filing a lawsuit against the state for that. So, and I think a lot of it has to do with a little bit like what Ginny was talking about, the scope creep, the different state medical associations lobbying to their legislators to kind of protect that honorific for physicians specifically. It's interesting because when you read, like particularly the Florida one, it seemed like it was focused more on nurses not being able to use the honorific doctor, ignoring sort of other professions that maybe have used the term doctor, like dentists or veterinarians or chiropractors. So it's kind of, so in some ways that makes it seem like it's targeting nurses specifically.
And women, perhaps.
Yes, and women.
Yeah. I mean, I think in my mind, if I'm trying to think of are there some, is this about concern about patients, going to somebody who, and they may be harmed, right? If this is somehow about that. If that's the case, then it should have nothing to do with the honorific, right? If it's about false advertising of what you have, what training you have, what experience you have, what expertise you have, I think then it's misguided, right? If it's about the honorific. I think it's fair to consider, because there are people out there, obviously, who are, who are perpetrating fraud. And, but I think tying that to the honorific doctor is just misguided.
Yeah, and I think that's what I really enjoyed about your essay is it sort of found this other solution to this scope creep concern, right? That, there's another way to solve the problem instead of this kind of gatekeeping, perhaps, which is a really elegant approach. Because I also can imagine times in which, a naturopath, for instance, I might not feel comfortable calling doctor if given, especially in a medical context, for instance. But I mean, one thing I'm sort of curious about is it feels like in most of our lives, honorifics have largely kind of faded away. I mean, whenever someone tries to call me Ms. or, God forbid, Mrs., I'm always sort of like flummoxed. It's a little bit like, well, why? Why are you calling me that right now? Why do you think doctor has stuck around when other honorifics have kind of largely faded to the wayside?
I think my personal opinion is that I think because there's some power and prestige associated with that particular honorific. I mean, it's really similar. I think I said like captain or general. Those are honorifics, and those are used in the military for that specific purpose of the hierarchy in the military, the power and respect of those particular titles. But outside of the military, do we really have a need for that anymore? I hear a lot of physicians talking about physician-led teams and that physicians are the ones who should be leading healthcare. And I constantly question, well, why? Like, what in your training or education makes physicians specific to leading healthcare change versus everybody else? I'm not saying that they don't have that. I'm just saying that there are other professions who have that as well. So yeah, I personally don't see a need for having that honorific anymore, especially with patients because of that hierarchy.
Mm-hmm. Yeah, that's interesting. I mean, I think it's a really convenient shorthand, right? That can be used, and then you don't have to do anything else to explain your position. And so it's an easy fallback. but, I don't know why that, why doesn't everybody get labeled with their training then, so it does seem silly when you
right.
kind of break it down. I think from the physician-led teams, I think that's really interesting too, Stephanie. I think what that is kind of arguing against is, and this is my bias, but it's arguing against the people in leadership in healthcare who have no experience with patients, right? So I think that's hopefully, in most cases, that's a way of saying, let's bring more people into leadership that actually have healthcare, face-to-face patient or, that kind of healthcare experience instead of just executives who may have never interacted with patients or the system or taken the risks that are involved with being, a healthcare provider. And so again, maybe hopefully it's a short form for just saying, let's bring more healthcare providers into leadership. But you're right. Maybe it's about something else and I'm being naive.
Yeah. I mean, so when I've specifically heard that term, it's nurse practitioners or nurses are a great part of a physician-led team. So it's definitely, and it's so interesting to me because like you could have a resident who is a physician and then a nurse who has a master's degree and 35 years of experience. Is that is that resident the one who's leading the team then? And I would argue probably it should not be.
Mm-hmm, mm-hmm.
One thing I see from doctors who seem to be concerned about scope creep is they say that there's cost cutting going on here, right? That healthcare systems want to avoid paying the higher salaries to MDs. And so, when they're hiring nurse practitioners or others, patients are getting a lesser experience and healthcare systems are just making more money. Might there be some truth to that concern as well?
I mean, that's tricky, I think. There certainly is, in our field, I can speak to in reproductive endocrinology and infertility, there are not enough REI, subspecialty board trained physicians to provide the care out there that needs to happen. That where patients are not being seen as quickly as they should be. And so I think there's that void is being filled in many different ways. And I think there's an attempt being made to also train more, but I mean, it's so multi-layered. It is expensive to train residents and fellows in medicine and, MD residents and fellows in medicine. And so the money's being cut from that standpoint by federal funding for those positions. And so I think there's a bit of a pushback against that. Like, hey, if this is what we're trained to do, help us train more, help us federally train more people to provide this care rather than filling the gap with, often excellent and well-trained, but not to that same requirements of the subspecialty fellowship trained providers. So I think there's probably that issue that it's true that there's less money for the training that's required for the MDs and for the subspecialty training. So it's tricky. Yeah.
I think overall that we have a huge issue in this country related to healthcare systems. They are a mess. I know that just in the last few months, healthcare system after healthcare system are laying off clinicians. I know my employer just laid off 350 employees last week. Very difficult. Some of them nurses. We need every single one of them. So it's really difficult to understand kind of this infighting, I guess I would say. And when this is really a time where physicians, nurses, everyone else in the healthcare workforce should be coming together to try to fix these situations and lobby to the government. Because I know Ginny and I will probably both say this, that we desperately need to fix things as sooner rather than later. And so fighting about things like scope creep or reimbursement rates to nurses versus physicians is kind of not the point.
Yeah, that's great. That's a great way of looking at it, Stephanie. Absolutely.
What do you think might be a more productive way to tackle these staffing issues than perhaps getting caught in the sort of gatekeeping over who gets to be called doctor?
That's a really hard question, Tori.
Please solve this in the next 3 minutes.
Yeah, I mean, I think, really coming together at the table. One of the things that I see as a nurse is that nurses are not always included at the table, which is very concerning. So, you might have, kind of like Jenny was saying, some executives and some physicians, but then there's not a nurse. So making sure that you have really all, clinicians at the table trying to solve these issues and work together. And making sure, we talk a lot about diversity, in these last 3 years, in a variety of settings. I know the American Medical Association talks about diversity a lot. But we have to think about diversity of our roles too, because every role is important and vital to the healthcare system. One role isn't superior to another. It's just, we all have different expertise. So that's why we all need to come together to try to combat some of these things. And we can't just ignore voices because we don't think that they have the training that we do.
Yeah. I mean, there's so many issues. Absolutely. I mean, things are, unnecessarily expensive, medications, people are underinsured still. And so catastrophic care is incredibly expensive. There are just societal issues, right, that, that are huge and that are unfortunately end up in the emergency departments instead of being solved, with better preventive care and just overall wellness. There's so many issues that, end up being kind of funneling down into, kind of complex healthcare issues for people in our society. And that including social determinants of health, right? I mean, so absolutely. I mean, the more voices, the better in figuring out, including public health and, and figuring out how can we help to make, just society healthier and prevent coming to, having to come into the system in the first place would be awesome.
Yeah, I know you all had a recent podcast about the physician, and I think is it Indiana, Caitlin Bernard, and you had 2 guests on about, just about how physicians or healthcare clinicians, need to lobby for patient safety and evidence-based medicine. And, these things are impacting nurses as well. And nurses are wanting to lobby these things too. So coming together, we form a bigger group and a louder voice.
So it sort of sounds like you're saying open the gate rather than keeping it closed. Gatekeeping is not the solution here.
Exactly.
Well, Stephanie W. Edmonds and Ginny Ryan, thank you so much for joining me today.
Yeah, thanks so much for having us, Tori.
Thanks, Tori.
While we're here, I wanted to let you know about something exciting from STAT. It's a new report called Patients Speak Out, Learning About Healthcare First Person. It collects some of the best first opinion essays about personal experiences with the medical system. I love it because it offers a really important reminder that healthcare is about people, something a little too easy to forget sometimes. You can find it at reports.statnews.com. Thank you so much for listening to the First Opinion podcast. It's produced by Teresa Gaffney. Alyssa Ambrose is the senior producer, and Rick Burke is executive producer. After this episode, we're going to take a little bit of a break. The First Opinion podcast will be back in October. In the meantime, please let us know what you think about the show, what we could be doing differently, and whether I did okay in my first season as host of the podcast. You can do that by sending us a note at first.opinion@statnews.com. And if you have a minute, please do take a second to leave a review or rating on whatever platform you use to get your podcasts. Until next time, I'm Tori Bosch, and please don't keep your opinions to yourself.